So we did 7 cases in the last 3 days, and of these we picked up 3 that we will be showing today. Now this is a kind of an experiment in sorts that we decided we will not have a live demo. The reason is that personally I feel patients suffer during live demos. We are so obsessed with the quality of the transmission, and we find it difficult to do follow-ups and all of them. We thought, so what we did is something like a replay of a cricket match, the highlights. So in that way we kept 3 cases. I will ask Ranjit to present the cases. He's one of our residents who loves IT. Anything you've seen with presentations, flash, it's all Ranjit's work, and he can do much more than that. So I'll invite Philip to come over to the table so he can sit, and we will show you the cases, and then we'll do the video runs, and this is the time you can ask your doubts, questions, and everything. So the first case is about a venous malformation in the lips.
Hello and welcome to our case discussion session for this afternoon. Over the past few days, we, along with Dr. Philip, have been seeing diverse cases of vascular malformations. Most of them we thought were amenable to treatment. With help of our radiology and clinical colleagues, cases from all over Coimbatore and few from other parts of India were referred to us. All the patients were subjected to a thorough clinical workup. Further assessment was made using MR and ultrasonography, and angiography was done on selected patients. We now present to you few of the most significant and the challenging ones for this discussion. The first case is that of a 10-year-old boy who presented to our clinic with a large and a grotesque swelling over the lip. His history revealed that the swelling was present since birth, which was small to start with and gradually increased in size. On clinical examination, the swelling was soft, non-pulsatile and compressible. There was no evidence of prill or bruit. Ultrasonography showed multiple locules of venous channels with no evidence of arterial involvement seen on color Doppler. MR was done on this patient, which showed a large soft tissue mass which was hypointense on T1 weighted sequences, hyperintense on T2 weighted sequences, enhancing well with contrast. Selective injection of external carotid angiography shows delayed pooling of contrast in the site of the lesion, which is consistent with a venous malformation.
Thanks. So I just asked Philip right now, when you saw this patient, what were your impressions, differential diagnosis, and what is your plan?
Venous malformation. I'm sorry, I'm very short with my words, but when we see a lesion like this, the 3 questions we always ask for any child is: what age was it first noticed at? What happened to the growth of this lesion since it was first noticed? This lesion was there actually at birth and has grown slowly in a commensurate fashion with him. There has been no cardiac failure. There has been no bleeding from this, I believe. And the clinical history was very typical for a vascular malformation. And when you clinically see the patient, you can see that there is no evidence of a high flow vascular malformation. There are no vesicles on the surface of this to suggest it might be a lymphatic malformation, and the MRI is compatible with a venous malformation. The one thing about the MRI, sometimes in venous malformations, is the contrast enhancement is not uniform, it's very slow flow, so maybe depending on the time you do the scan after the injection may not show a lot in the way of, but the fact is you do get enhancement, and it is different to lymphatic malformation. So the clinical diagnosis fitted with the venous malformation, it was confirmed with MR, and you'd go on and do treatment with sclerotherapy. But you would also consult with maybe your surgical colleagues to see if there were some combined options, and probably ultimately with this, after several sclerotherapies, after a long time for this size lesion, he may be amenable to sort of plastic reconstruction. So he's actually got deformity of his lower jaw as well, his teeth are distorted. So, the dentist will have to seed him and assess him, and maybe facial maxillary surgery or plastic surgery as well. So that's it in a nutshell.
The only reason I asked is this patient is referred to us as an arteriovenous malformation for embolization. So, what you're trying to say is that the fundamentals, the diagnosis, yes, what? Why the angiogram was arterial? Why was the angiogram done? Well, no, not for that. I mean, the reason we did the angiogram is, though we know there are venous malformations, we just ensure that there are no fistulas, because we're going to shoot something and we don't want it to be washed up early, that's all. Does that mean that all venous malformations which we on clinically or MRI we know that there are venous malformations we have to do?
No, definitely not. Absolutely not. Years ago we used to do it. It actually shows a very typical appearance of a venous malformation on an arteriogram. You get these little puddles at the arterial injection where there's contrast being deposited throughout the malformation. But the answer is no. No.
Part of the reason was because we were working them for the workshop. We didn't have time to do an angio the day he came.
So he had the angiogram before this.
We sent all the images to him and then we did it. Technically there's no pulsation, no flow, no. Okay.
But it illustrates very nicely what venous malformations look like anywhere on arteriography.
Which that?
So I've not. These are all new. I've not actually seen these videos, so I don't know how fast I have to talk or slow I can talk. Okay, but we decided to do injection sclerotherapy, and this was his first sitting. So the important thing is to know what position to put the patient in. So if you have lesions, for example, at the back of the calf, in order to do sclerotherapy, you'll need to turn the patient prone. So all procedures that I do actually back in Canada are done under general anesthesia. So our anaesthetists need to know if the patient needs to go prone, because they'll have to intubate with an endotracheal tube.
To interrupt you, I mean, we are showing a ventilator. Do you all of them on the GA?
Yes, they're all in the GA. We have controlled ventilation, so they're paralysed, because depending on where the malformation is, it may get distorted by respiratory movements and chest wall movements. So usually, but for example, if they're in an extremity, the patients are not paralysed.
So that is the tetrabenzyl students taken. Each of them are 2 cc, and there is 30 milligrams in each of them. And this is something that we learned from Philip. Small thing, but it makes a big difference. Cutting the range of the scalp pain makes you put several more scalp pain needles together, because otherwise those glands keep touching each other. So that's it. So we can see what we've got is 4 ml.
So
Isn't that 4 ml of air?
So what we do to make up the sclerosing foam is very easy. We add an equal volume of air to the volume of 3% sodium tetradecyl sulfate. The mixture does separate. The foam is a detergent sclerosant, so it easily separates. So while you're waiting a few minutes to inject it, it'll separate, the fluid will come out, and the foam will separate. So you can stabilize it by adding a little bit of Lipiodol. If you want to add 1 or 2 cc's of Lipiodol, it'll stabilize the detergent foam. So
see the needles being placed. The needles hubs are like open, allowing free flow of blood, which is the technique that we said that brings down the pressure within